Welcome everyone to our next session, Caregiving for Children with Genetic Conditions and Caregiver Workforce Participation. It is my distinct pleasure to be able to introduce Liza Creel, PhD, MPH, and Associate Professor in the Division of Healthcare Policy and Research at the University of Colorado Anschutz Medical Campus. It's my pleasure because Liza used to sit in this chair that I sat in when I first reached out for help on our genetics journey. Please reference this next slide for our continuing education statement, as well as Liza's learning objectives and disclosures, of which Liza has none. With that, I would love to turn it over to Liza and let her share her screen. Take it away, Liza.
All right, thank you. Hopefully everyone can see that now. Thank you, Christy, for the introduction. And thank you all for joining this session today. I'm really thrilled to be here for 100 different reasons, all of which would take my whole allotted time to go through, but including that work in the area of children with genetic conditions and supporting families of children with genetic conditions is very near and dear to my heart for many reasons, including because of some of the people I've been able to meet, like Christy, in doing some of this work. I'm really excited to share some recent work I've been doing looking at caregiving, specifically among caregivers of children with genetic conditions, and looking at caregiver workforce participation. As a little bit of context, and I know you can read my bio on the attendee website, but I just want to sort of position myself as relevant in my experience and expertise in doing this work. I am a health services researcher, which means I study access to care, I study quality of care and cost of care that is delivered within healthcare systems. I'm not a clinician. I look more at systems of care and policy related issues. And I'm specifically interested in systems of care that serve or could better serve children and families, including those with genetic conditions. As Christy mentioned, I have no financial disclosures or conflicts of interest to report. Today, we are focused on two learning objectives. The first is to describe the current literature on caregiving for children with special health care needs, including those with genetic conditions. And the second is to explain workforce participation among caregivers of children with genetic conditions. Before we get started, I want to acknowledge two of my collaborators here at the University of Colorado Anschutz Medical Campus, Dr. Judith Owlett and Sarah Byers, both of whom have been critical partners in reviewing both our methodology and interpreting our results. So first, let's just kind of start with a little bit of background. And I think many of you are very familiar with some of the statistics I'm going to share with you, but I just want to ground us in sort of where we are and how we're thinking about the population of children with genetic conditions. In their study published in Genetics and Medicine in 2022, Jessie Lickstein and her co-authors found a prevalence of about 3.9% of children in the United States with a genetic condition. In their study, they used data from the National Survey of Children's Health. A genetic condition in this work was identified using parent and/or caregiver reported responses on whether the child had any previous diagnosis of one of four medical conditions, including blood disorders, cystic fibrosis, Down syndrome, or other genetic or inherited conditions. So this included inherited metabolic conditions, Down syndrome, blood disorders such as sickle cell disease, and cystic fibrosis. This definition is important because we apply the same definition in our analyses, which I'll present shortly. Their study also found that children with genetic conditions have increased healthcare utilization. And though they generally have some health insurance coverage, they are more likely to have unmet healthcare needs. Why might that be? Well, it's possibly due to the complexity of needs among children with genetic conditions and really a limited workforce. Caregivers of children with genetic conditions, like many other caregivers, provide a variety of supports, including care coordination, system and insurance navigation, physical supports, psychosocial supports, and other services and supports such as transportation. Caregiving can be time-consuming, with some suggestions that family caregivers provide about 1.5 billion, that's billion with a B, 1.5 billion hours of healthcare annually to children with special healthcare needs. Many caregiving activities must be performed during regular business hours, suggesting a potential impact on employment and participation in the labor market. So why do we care if parents or caregivers of children with genetic conditions participate in the workforce? Well, first of all, loss of or a reduction in employment can have important economic implications for families. Even if another parent or caregiver is working, loss of employment may significantly impact income, which in turn could lead to financial stress. Employment is also a source of pride and self-efficacy that people may value and not want to lose. Family caregiving is increasingly becoming a national priority. In 2022, the Administration for Community Living published the National Strategy to Support Family Caregivers. This strategy is broad and focuses on all types of family caregivers, from those caring for children to those caring for spouses, to those children who are caring for adults. I'm quoting from the press release announcing the strategy. It highlights nearly 350 actions the federal government will take to support family caregivers in the coming year, and more than 150 actions that can be adopted at other levels of government and across the private sector to build a system to support family caregivers. Family caregivers, who provide the overwhelming majority of long-term care in the United States, currently lack resources to maintain their health, well-being, and financial security while providing crucial support for others. I want to call out Goal 4 of the National Strategy, which is to ensure financial and workplace security for family caregivers. They note strategies around paid leave policy, discrimination protections, expansion of family leave programs, flexible workplace policies and practices, financial planning resources, and more affordable long-term services and supports to reduce out-of-pocket costs for families. Relatedly, there is a call for more work and focus on caregiving specific to children and youth with special healthcare needs. In a special issue of the journal Academic Pediatrics, Clarissa Hoover and co-authors published a paper, Understanding Caregiving and Caregivers, Supporting Children and Youth with Special Healthcare Needs at Home. This is part of a larger body of work established through the Research Network on Health Systems for Children and Youth with Special Healthcare Needs, which is funded by the Health Resources and Services Administration. This paper outlines gaps in support and in support for caregivers of children and youth with special healthcare needs, and proposes strategies for better understanding caregiving and better supporting caregivers. Several studies have demonstrated that parents of children with special healthcare needs or complex medical needs are more likely to miss work or leave the workforce. In a 2009 study, Okumura and co-authors used the National Survey of Children with Special Healthcare Needs to examine job and work loss among family caregivers of children and youth with special healthcare needs. They found that more complex medical needs increased the odds of caregiver work loss. They also found that the presence of a medical home reduced odds of work loss, which suggests that systems of care can support families. There's very limited data exclusively focused on caregiver health, particularly for adult caregivers of children. So most analyses are limited to national survey data, which is also what we use in the study I'll present shortly. It's important to point out that family medical leave laws, both federal and state, and some state policy allowing payment for family caregiving under certain circumstances are designed to support caregivers and protect from loss of employment and income, at least in part. To our knowledge, there are no other studies of work loss among caregivers of children with genetic conditions. So we decided to look at it. The purpose of the study I will now present was really to examine the association between caregiving for a child with a genetic condition and that caregiver potentially experiencing work loss. Now, you may be wondering why this very specific area, why do this, why this when families face many barriers to care and services. Family caregiving is an important policy issue, but it's also highly relevant for community care delivery. Many caregivers that have to leave the workforce risk financial instability. We know from many models of the social determinants of health that non-medical factors, including socioeconomic factors, impact access to care and health outcomes. Recognizing other factors outside of healthcare that may influence family well-being can help you consider appropriate referrals for social supports, but also envision policy changes that may support families and caregivers in achieving both their medical and non-medical goals. For those of you who are not methodologists, please bear with me for a moment as I review our approach to this study. We used 6 years of data from the National Survey of Children's Health, which is a nationally representative survey of non-institutionalized children ages 0 to 17 years in the United States. Now, let me note a few things about this survey. Prior to 2016, the federal government operated 2 national surveys, the National Survey of Children's Health and a separate National Survey of Children with Special Healthcare Needs. Those surveys were combined in 2016 using a new sampling strategy and with the addition of a number of questions, including one about genetic conditions. This was a significant advancement in the survey design, but also means we are unable to compare the newer data to those that were collected under the 2 earlier versions of the survey. So using data from this combined survey, we identified the presence of a genetic condition using the approach from Lichtenstein et al., which I summarized earlier. As a reminder, we coded a child as having a genetic condition if the parent or caregiver reported in the affirmative, so said yes, that they had ever been told the child had a blood disorder, cystic fibrosis, Down syndrome, or another genetic or inherited condition. I'll note this excludes, by definition, autism and other disorders. Our first step was to estimate an updated prevalence of children with a genetic condition in the United States. Then we used regression analyses to study the primary outcome of interest, caregiver work loss. We identified caregiver work loss using 2 questions from the survey. One that asked if the caregiver had left the workforce in the past 12 months due to the child's health status, and another that asked if the caregiver had reduced work hours in the past 12 months due to the child's health status. If either of these were answered in the affirmative, we determined that there was work loss present. Following the design used by Okumura, we incorporated key child and family level covariates in our adjusted model to control for other factors that may influence work loss and to understand circumstances under which the probability of work loss increases. We tested for the association between caregiving and a child with a genetic condition, caregiving for a child with a genetic condition, and caregiver work loss in the prior year using multivariate logistic regression analysis in the software program Stata 18. This analysis accounted for the complex sampling design of the survey. Finally, based on the regression results, we estimated predicted probabilities of work loss for key variables in the model. Our final weighted sample includes over 57 million non-institutionalized children ages 0 to 17 years in the United States. So one of the first things we did was just look at overall characteristics of the two groups in our study. And the two key groups we're comparing here are children with genetic conditions and children without. When we do some descriptive comparisons of children with and without a genetic condition, we see these two populations are different. Now, what I'm about to summarize are just descriptive analyses. They aren't adjusted models accounting for everything at once. We'll get there in just a few minutes. Even so, on these descriptive comparisons, we observe differences in caregiver work loss, with a higher proportion of those caring for children with a genetic condition experiencing work loss. We see differences in special needs status, which is different than having a genetic condition. Not all children with a genetic condition have a special need, at least according to the definitions in the survey. But a larger proportion of those with a genetic condition do have a special healthcare need. We see differences in race, with fewer of those who are white or Hispanic having a genetic condition, and more of those who are Black or non-Hispanic having a genetic condition. We see variations in age, with a higher proportion of children with genetic conditions among older children. Those who have functional limitations, or children with genetic conditions, have a higher proportion of those with functional limitations, I'll note that functional limitation was measured using parent and caregiver reporting that the condition limited the child's activities. When there were children with genetic conditions had more unmet needs. This is similar to the findings of the Lichtenstein study. A larger proportion of children with genetic conditions lived in a single parent household. More children with genetic conditions live in a household with an income below 200% of the federal poverty level. And more children with genetic conditions have public insurance or a mix of public and private insurance, which is consistent with other statistics that are out there. I'll also note that there's a higher proportion of female caregivers among among children with genetic conditions. We observe no difference in caregiver education between the two groups. Okay, so let's start with a few key overarching findings. I mentioned that we calculated an updated prevalence of children with genetic conditions, and our findings suggest a slightly higher prevalence of 4.3% than what was estimated in the Lichtenstein paper, which you may recall was around 3.9%. Now, their analyses only used 2 years of the survey data from the National Survey of Children's Health, and we have the advantage of doing this work in 2023 and now having 6 years, almost 7, because the 2022 data just were released. Overall, for all children in the sample, 6.3% of caregivers reported work loss due to caring for a child. When we look at this across different types of children, we observe that around 1/5, or 21.4% of caregivers of children with genetic conditions report work loss. That is compared to 15% of children, of those caring for children with other special healthcare needs, but no genetic condition, and 3.6% of caregivers for children with neither genetic conditions nor other special healthcare needs. So this begins to tell a story of a potentially substantial impact of caregiving on workforce participation for caregivers of children with both genetic conditions and special healthcare needs. Now, before I start sharing the results of our regression analyses, let me go through a couple of interpretations of the statistics I'm going to share. First of all, I mentioned that we used a multivariate logistic regression to estimate associations between key variables and caregiver work loss. What that means is that we use statistical models to determine the presence and strength of a relationship between two things. We report this in this type of model using an odds ratio. An odds ratio tells us the relative odds that something occurs, given some characteristic that is present or some exposure. An odds ratio over 1 indicates a higher odds of something happening. An odds ratio under 1 indicates a lower odds of something happening. It's important to note that this measure really looks at the relationship or association between two things, but does not indicate whether one thing causes the other. Now, the term you see in the blue box on this slide, the little a, big OR, that stands for adjusted odds ratio, just indicates that the odds ratio is adjusted for other factors that may also impact work loss. The p-value tells us how likely it is that our findings are only due to chance. The lower the p-value, the more confidence we have in our findings. Relatedly, the confidence interval, or what you see as CI there, is essentially a range of values that account for possible variation in our estimates. This is the range of values that we might expect the true value or other estimates to fall within. Finally, I'm going to report differences in predicted probabilities between groups. This is a way of presenting the findings in a more clinically and practically meaningful way, as odds ratios can be difficult to interpret and apply. So our key exposure, if you will, in this study is a genetic condition. Our analysis reveals that caregivers of children with a genetic condition have over 2 times the odds of work loss compared to caregivers of children without genetic conditions. This relates to a 5% difference in probability of work loss, with those caring for a child with a genetic condition having a probability of around 11% that they will experience work loss, compared to just over 6% for those who care for a child without a genetic condition. Now, these models show results for key relationships and hold all other things constant, something we love to say in economics and statistics. So regardless of other factors, if the caregiver cares for a child who has a special health care need, as defined in the survey, the odds of work loss are almost 4 times those caring for children without a special health care need, equating to a 10% difference in probability of work loss. Certainly, if a child has both a genetic condition and a special health care need, the probability is likely to increase. We also observe differences in work loss for those of different races and ethnicities. Caregiving for Hispanic children and those with 2 or more races increases the odds of work loss. The statistics you see on your screen are specific results for those who are of 2 or more races and Hispanic. When a child has functional limitations, caregivers are more likely to experience work loss with an 8% difference in probability. A higher probability, of course, of work loss when the child has functional limitations, suggesting more demand for their time and skill at home. Similarly, when there are unmet healthcare needs, caregivers are more likely to experience work loss. If a child lives in a single parent household, caregivers are still more likely to experience work loss with a slightly higher probability, a difference of about 1.5%. We also observe a higher probability of work loss in households below 400% of the federal poverty level. These are results for families. What you see on your screen really are results for families who are in income levels that are between 200 and 399% of the federal poverty level compared to those over 400%. This suggests, of course, that financial instability may be exacerbated for those lower income families. And finally, caregivers of children with public or some mix of public and private insurance have higher probability of work loss. We see decreased odds or decreased probability of work loss for caregivers of older children and for female caregivers, though the latter may be due to initial workforce participation. As with any even great study, there are limitations of this work. First, the survey data include years during the pandemic. So we had 2016 through 2021. We know during the pandemic, there was substantial and widespread job loss. Now that job loss was unrelated, presumably, to a child's health, but could affect parent and caregiver responses. Second, a genetic condition in the context of this analysis may really be a proxy for medical complexity more generally. And this is something we're actually looking into to make sure that our results are robust to different comparisons that we might make. We relied primarily, because of what is available, on child demographics and have limited information about caregivers or other caregiver level factors that may influence workforce participation. And finally, our national focus limited our ability to look at state-specific outcomes or variations in work loss based on state resources or policy variations. So, for example, we know that many states allow for paid family caregiving under certain Medicaid waiver programs or other policy interventions. This study does not account for those variations. So in this study, we find that caregivers of children with genetic conditions experience work loss at a higher rate than caregivers of other children, even caregivers of other children with special health care needs. Children with genetic conditions experience medical complexities that may influence workforce participation among caregivers. Caregivers of children with unmet health needs are more likely to leave the workforce, suggesting very complex challenges in access to care and other community supports. We also observe that there are persistent racial disparities that are present. The risk factors for work loss may be useful for informing policy or other strategies to support caregivers of children with genetic conditions. We see that family caregiving is an area of increasing policy and research importance. Children with genetic conditions and their caregivers face substantial medical and care coordination needs with possibly limited access to subspecialty care and other supports. For you all as providers and advocates, understanding risk factors for job loss and reductions in employment may help you consider family supports that minimize the risk of financial instability and maximize family health. While the medical and even healthcare delivery systems are unlikely to resolve or address work loss alone, we know that community health is related to family health, and family health is related to individual health of both the caregiver and of the child or children. Policies to support caregivers through respite, specialized childcare, coordination tools, and other resources may support caregivers in focusing their attention and time where it is most needed without needing to leave the workforce or reduce work hours. And with that, I am finished.
Thank you, Liza, so much for your presentation and making statistics understandable for those of us who do not specialize in that field. You have a way with data, and we love you for that. So we have quite a few questions that have come in, and I just want to encourage everyone that is listening to use the QA feature on the attendee website to share your questions with Liza, because we have some time here that we can have a discussion about some of those questions. So one I'd like to start off with, if it's okay with you, is how do we think about how to approach policy change to support family caregivers overall, but specifically for children with genetic conditions?
Yeah, that's a really good question. So I think there's work towards doing this and doing it well. I think the first step really is more research that looks at this, but more specifically engages family caregivers in that research as members of research teams and as participants in those studies, so that we really have a better understanding of the strategies that would support whatever that desired balance of work and life is. That's going to be different for every family, and the expectations for that balance will be different for every caregiver. And then we need to use what we learn, right, to inform policy and other practice-based strategies to support families.
Great insight. Thank you so much for that. One question about genetic condition designation. So does the genetic condition designation have certain qualifiers? So for example, is molecular confirmation required or tracked at all as part of the data? What if the patient meets the clinical criteria, but maybe has a negative or non-diagnostic molecular results? So could you talk about that in relation to the survey?
Yes, the answer to all of those is no. I'm sorry to say that would be fantastic. This is all self-report, and it's self-report by the parent. So they are, basically asked for each of those 4 categories of medical conditions. So blood disorders, Down syndrome, cystic fibrosis, and then literally the language is genetic or inherited condition. The caregiver, the respondent basically says, yes or no, I've ever been told my child had that. So there's definitely some potential reporting bias here insofar as somebody recalls, being told it was genetic and not something else. And there is certainly no clinical validation of that report.
Thank you for clarifying that, because that's an important designation in this data. Also, something else to consider, again, maybe some survey bias as well, but have you seen anything in the literature or in the survey about undiagnosed complex potential genetic disorders and this topic? So an area where someone might not have been told it's a genetic condition yet because they're on a diagnostic odyssey, as we sometimes say.
Yeah, that is such an excellent point, and potentially even more impactful on caregiver employment and workforce participation. To my knowledge, no one has looked at this. The survey itself does not include a question about sort of current pathways toward diagnosis. And so we really can't explore that with that specific survey. It's a really good point that we're sort of skipping this other time period in people's lives that may be disproportionately affected because of those experiences. A great point.
Thank you. Maybe an idea for future research.
That sounds like a good what's next question.
Absolutely. And I'm not sure if you know this, but if you can point us in any directions of where we might find any resources available for parents of children with genetic conditions who are terminated by their employers for the time required to take care of their children. Have you come across any of that in your work, or know of any places that might be helpful?
Yeah, so this is absolutely outside of my area of expertise. I want to be very clear. This is those are conversations that are generally have attorneys present. So I do think probably in the area of, the family medical leave policy area, and sort of leave policy more generally. We have federal laws that regulate that. There are also state specific laws around family leave, and those can vary. I would say starting there, like I said, there's a lot of conversation around doing better around discrimination, for example, because of family leave or family caregiving. I'm not aware of resources specifically for this, but would absolutely be willing to investigate that a little more and provide anything that I come across.
Thank you. And thank you for making your contact information available for anyone who would like to reach out to you about specifics. Also, can you answer what if this again might be outside of the scope of this work, but there's a question asking about any data or work considering epigenetics and economic cost burden of epigenetic conditions, again, might be outside of the scope of this survey.
Yeah, so I think it's definitely outside of the scope of the survey, but I think it's a really interesting area and a little different way to look at this, right? So I've focused, and our team is focused very specifically on this one aspect of financial stability, which is employment and income generation. There's also sort of the outgoing part of financial and economic security. And that's, what are you having to spend, right, in order to do these things, to care for a child, to support your family in the way that they need. And that's a different type of analysis, sort of what are the economic costs to the family, to the system, to the payers, to society, if you will, of epigenetics or specific conditions, that sort of thing. It's an area of a lot of interest and work. Not something I have done.
Thank you for your honesty, but another great topic that could be explored down the road.
And I'll add to that certainly in the National Strategy for Family Caregiving, there are some recommendations in there specific to out-of-pocket cost reduction, right? So if a family member chooses to or has to leave the workforce, those costs of paying for care don't necessarily change and may actually increase because of insurance loss and other things, or changes in coverage. So certainly a focus on out-of-pocket costs and like real cost to families is a priority.
Absolutely. And we have one question asking if you could be more clear about the use of the term blood disease as a genetic disorder.
Yeah, this is another good question. I will mention that we a lot when the survey, with the two surveys were combined, there was a question I think I mentioned that was added to get at whether or not a caregiver or parent had ever been told that the child had a genetic or inherited condition. But there were other questions that carried over from prior versions of the survey, like ever been told the child had Down syndrome or cystic fibrosis or a blood disorder. I believe the examples that are given in the survey around blood disorder are sickle cell and thalassemia. As two examples, the Health Resources and Services Administration, who provides the resources for these surveys to be done, did a lot of work when the 2016 survey data came out to look at those questions and identify an appropriate algorithm, if you will, for identifying genetic condition, because they knew if we isolated it just to this question about genetic or inherited, we might be excluding those other questions that also have a genetic basis. And so that Lichtenstein paper really set out the strategy for using these survey data to identify a genetic condition. I will say I have presented this in another setting where I got some feedback that, you know, it would be wise to maybe include autism as part of this. My goal with this is to be consistent with what else has been reported in the literature, which is why I wanted to use the same definition. But there's certainly opinions and perspectives on different ways that could be operationalized using the survey data.
Great point. And that goes along with another question we have asking how long until autism falls under the genetic disorder umbrella. Imagine the effect that this will have. So do you want to comment on that any further?
I don't know the answer to that. Right. I do think, and this is something I mentioned to you all, a limitation of this work. This is also a comment I got after presenting this at a different conference. A limitation of this is, you know, we're looking specifically at this indicator of, and I'm quoting genetic condition because that's the phrase I'm using. But does that really just imply that because most children with genetic conditions have medical complexities, that's really about the complexity of the disease and not the fact that it's genetic that's really driving this? And so one of the things we are doing is some what we call robustness checks. Let's look at this when we group families or kids into just groups of children with medical complexity. Let's look at it for caregivers of children with autism and see how the results vary, if they're persistent, if they change how we might interpret these results at all. It's a super important point. I don't know the answer to that question though.
Yeah, no worries. I just saw it pop up and it went along with the other one. There is also a question about some of the areas, specifically in the Mountain States region, you know this well, where there's not available genetic services or coverage for Medicaid children. And so just a comment about the discrepancy in the data, if this is the case, is there a plan to address the areas without genetic options?
Yeah. So this is a sort of future research area, right? We actually have enough data now because we can combine multiple years, and so our sample size gets larger. We actually can start to look at some state-specific variations, and that's sort of our next extension of this. It would be, I think we can look at that with measures that are proxies for geographic access to care. We can look at that with, the lens of different policy variations, right? Is there a paid family leave policy present in that state versus states that don't? And do our outcomes vary based on that? So I think we're finally at a point with 7 years of data in the survey that we can start to do some for small populations, right? Because overall populations of children with genetic conditions are small, but now we have enough years of data that we can combine those and have a sample size that's substantial enough to actually explore those state-specific differences.
Great answer. And one person is asking if you looked at specifically the percentage differences between complete loss of work versus the reduced hours.
Yeah. Yes and no. We've sort of explored that. What I mentioned, the 2009 study, and that study used the National Survey of Children with Special Healthcare Needs, which also had these workforce participation questions. And so again, to try and be consistent with the estimates in that study, and here I combined them. What I can tell you is that when you look at this for just caregivers who left the workforce, right? No reduction in hours, that's sort of excluded from this. There's still about 12, almost 13% of caregivers who indicate they left the workforce. And that's caregivers of children with genetic conditions. So, adding in those who reduce their work hours, it goes from almost 13% to 21%. So that it makes a big difference to combine those, but both are substantial on their own and higher than what we see for caregivers of other kids.
Great. Thanks for going into that and giving some more context. And we also have a comment that says, it seems like your research supports what makes sense and what everyone's observed, what we've all observed. Is there hope with the hard numbers that we can actually impact change with our policymakers? Or do you have any suggestions on how to do that?
I love this question. I think if policymakers don't have data, if they don't know something is an issue, they're definitely not going to do anything to change it. But data is not sufficient either, right? Because we've been showing lots of things are problems for a long time and there's still no policy interventions. I do think the momentum is there. And that's for a couple of reasons. One, we've had some federal laws that have asked the agencies, the Administration for Community Living specifically, to look into family caregiving. We see an emphasis placed on caregiving in the research network for children with special healthcare needs. So we start to see sort of the discussion bubbling up. We're seeing caregiver-related sessions and panels at national conferences. And that just means that we're getting the word out, right? And sharing results and giving data. It's important for those of us who are academicians to publish, but also to translate that into documents that are helpful for the public and for people in decision-making roles who are never going to read the paywall journals that I'm going to publish this paper in. And so I think sort of combining the dissemination efforts that, engage the academic audience, but also the public and the advocacy and the policymakers and other agency level decision makers in this can really tip the scale on action. But it's also hard. to do. I highly recommend, if this is an area you're interested in terms of policy change, looking at that national strategy. It of course focuses on caregivers of all different types, but I think does a really nice job of outlining where the government, the key policymakers at both the federal and state level, can start to do some work.
Great. And with that, you've brought us right to the end of our Q&A session. I just want to thank you again, Liza, for sharing your expertise with us.
For more information, visit mountainstatesgenetics.org/contact. This activity was brought to you by Mountain States Regional Genetics Network. Please enter this code in the evaluation survey in order to claim Genetic Counseling CEU. GS23-06.